In today's video, we shall discuss about Corynebacterium diphtheria. Before moving on to the video, do let me know your opinion and suggestions in the comment box. Also, feel free to suggest the topic that you wish to see in the coming videos. So without wasting much time, we shall see what Corynebacterium diphtheriae is. This is the bacterium that caused diphtheria and was first described by Klebs in 1883 and was cultivated by Loeffler in 1884, who applied Koch's postulates and properly identified Corynebacterium diphtheriae as the agent of the disease. In 1884, Loeffler concluded that Corynebacterium diphtheriae produced a soluble toxin, and thereby provided the first description of a bacterial exotoxin. Roux and Yersin in 1888 discovered the diphtheria exotoxin and established its pathogenic effects. The antitoxin was described by von Behring in 1890. Corynebacteria are gram-positive, non-acid-fast, non-modal rods with irregularly stained segments due to the presence of granules in some species. They frequently show club-shaped swellings, hence the name Corynebacterium from Coryn, meaning club. The most important member of the genus is Corynebacterium diphtheriae, the causative agent of diphtheria. The morphology of Corynebacterium diphtheriae is as follows. They are slender gram-positive rods, pleomorphic, and easily decolorized. They are 3 to 6 micrometer in length and 0.6 to 0.8 micrometer in diameter. They are non-sporing, non-capsulate, and non-modal. They possess polymetaphosphate granules that serve as storage granules and are called volutin or Babes-Ernst granules or metachromatic granules. These give the bacilli a beaded appearance when stained with aniline dyes. Special stains for demonstrating the granules are Albert's stain, Neisserer's stain, and Ponder's stain. The bacilli are arranged in characteristic pairs, palisades, resembling the stakes of a fence, or small groups. The bacilli lie at various angles to each other, resembling the letters V or L. This is called Chinese letter or cuneiform arrangement due to incomplete separation of daughter cells after binary fission. Moving on to the cultural characteristics. Corynebacterium diphtheriae are aerobes as well as facultative anaerobes. Their optimum temperature for growth is 37 degrees Celsius. Growth is scanty on ordinary media. Enrichment can be done with blood, serum, or egg for good growth. Potassium tellerite 0.04% acts as a selective agent, as it inhibits growth of most oral commensals and retards the growth of Candida albicans and Staphylococcus aureus. Their optimum pH is 7.2. In blood agar, they are small, granular, and gray with irregular edges. Hemolysis may or may not present. In Loeffler's serum slope, they have very rapid growth. Colonies forms in 6 to 8 hours. Initially circular white opaque colonies and a gired yellowish tint on incubation. In tellerite blood agar, growth slow. Colonies seen after 48 hours. The colonies are brown to black with a brown-black halo because the tellerite is reduced to metallic tellurium. This medium is a selective medium, can be prepared by incorporating potassium tellerite, 0.04%, in the blood agar medium. In Tinsdale's medium, which also contains cysteine in addition to tellerite, the colonies with gray-black and dark brown halos indicate Corynebacterium diphtheria and Corynebacterium ulcerans. These contain cysteinase. The Tinsdale medium is also a selective medium. It can be prepared by incorporating bovine serum, cysteine, and potassium tellerite in sheep's blood agar medium. Now, we shall see the classification of Corynebacterium diphtheria. Based on colonial and other characteristics, Corynebacterium diphtheria are classified into 3 types: Corynebacterium gravis, Corynebacterium intermedius, and Corynebacterium mitis. 3 morphological types of Corynebacterium diphtheriae are found on tellerite-containing media. Mitis have black colonies with a gray periphery. Gravis have large, gray colonies, and intermedius have small, dull gray to black colonies. Type differentiation of diphtheria bacilli. Antigenic structure. Diphtheria bacilli are antigenically heterogeneous. They carry 3 distinct antigens. A deep-seated antigen found in all corynebacterial species, as well as in Mycobacterium tuberculosis. A heat-label protein, K antigen, and a heat-stable polysaccharide, O antigen. By agglutination, gravis strain have been classified into 13 antigenic types, intermedius into 4, and mitis into 40 types. Pathogenicity. In nature, Corynebacterium diphtheriae occurs in the respiratory tract, in wounds, or on the skin of infected persons or normal carriers. It is spread by droplets or by contact to susceptible individuals. The bacilli then grow on mucous membranes or in skin abrasions, and those that are toxigenic start producing toxin. Toxin. Virulent strains of diphtheria bacilli produce a very powerful exotoxin. The pathogenic effects of the bacillus are due to the toxin. Almost all strains of gravis and intermedius, about 95 to 99%, and mitis, about 80 to 85%, are toxigenic. It consists of two fragment A and B, of molecular weight 24,000 and 38,000. Both fragments are necessary for the toxic effect. When released by the bacterium, the toxin acts by as inactive because the active site on fragment is masked. The toxin is label. Prolonged storage, incubation at 37 degrees Celsius for 4 to 6 weeks, treatment with 0.2 to 0.4% formalin or acid pH converts it to toxoid. Toxoid is a toxin that has lost its toxicity but not its antigenicity. Mechanism of action. The diphtheria toxin inhibit protein synthesis. Specifically, fragment B helps in binding and fragment A inhibits polypeptide chain elongation in the presence of nicotinamide adenine dinucleotide by inactivating the elongation factor, EF2. It has a special affinity for certain tissues such as the myocardium, adrenals, and nerve endings. Following are the common symptoms of the disease. Clinical features. The site of infection may be otitic, genital, which includes vulval, vaginal, or preputial, pharyngeal, most common, laryngeal, conjunctival, or cutaneous. Pharyngeal diphtheria is the most common type and may vary from mild catarrhal inflammation to very widespread involvement. Sometimes diphtheritic whitlow or ulcer may occur. Based on clinical severity, they can be classified into malignant or hypertoxic, which there is severe toxemia with marked adenitis, bull neck. Death is due to circulatory failure. There is a high incidence of paralytic sequelae in those who recover. Septic, which leads to ulceration, cellulitis, and even gangrene around the pseudomembrane. Hemorrhagic, which is characterized by bleeding from the edge of the membrane, epistaxis, conjunctival hemorrhage, purpura, and generalized bleeding tendency. Common complications are asphyxia, due to mechanical obstruction of the respiratory passage by the pseudomembrane, for which an emergency tracheostomy may become necessary. Acute circulatory failure, which may be peripheral or cardiac. Post-diphtheritic paralysis, which typically occurs in the 3rd or 4th week of the disease. Palatine and ciliary, but not papillary, paralysis is characteristic, and spontaneous recovery is the rule. Toxemia, in which the bacilli remain confined to the site of entry, where they multiply and form the toxin, which is absorbed and produce toxic damage to the heart, myocarditis, kidney, tubular necrosis, liver, and adrenal glands. Local necrotic changes, leading to fibrinous exudates. These, together with the disintegrating epithelial cells, leukocytes, erythrocytes, and bacteria, constitute the pseudomembrane, which is characteristic of diphtheritic infection. Mechanical, caused by the membrane. Non-toxigenic strains, which may cause infection even in immunized individuals, as immunity with the toxoid does not confer antibacterial immunity. Such infection is mild, though pseudomembrane formation may sometimes occur. Cutaneous diphtheria. In the tropics, diphtheria bacilli infect the skin more often than the respiratory tract. Toxigenic diphtheria bacilli may persist in the skin for over 3 years. It is found in people with poor hygiene. Any break in the skin can become infected with diphtheria. The infected tissue develops an ulcerated area and a diphtheria membrane may form over the wound, but is not always present. It is slow to heal and may be insensitive when touched. Fomites do not seem to play an important role, though in special situations, toys and pencils may act as vehicles of infection. Typing. Typing methods are used to determine the transcontinental spread. Biotyping. This is done based on biochemical tests, mostly using automated systems. Ribotyping. This is presently considered to be the most useful method to type the strains of Corynebacterium diphtheriae. Common molecular methods include pulse field gel electrophoresis, random amplification of polymorphic DNA or amplified fragment length polymorphism. Bacteriophage typing. About 15 bacteriophage types have been described. Types 1 and 3 are mitis, 4 and 6 are intermedius, 7 avirulent gravis, and the remaining are virulent gravis. The phage types are apparently stable. A system of bacteriocin, diphtheria, typing has also been described. Other methods of typing includes bacterial polypeptide analysis, DNA restriction patterns, and hybridization with DNA probes. However, due to poor discriminatory power, this is not used any longer. Laboratory diagnosis. Specimen. Preferably, 2 Dacron swabs from the lesions are collected under vision, using a tongue depressor from the lesion. The area under the visible membrane should be sampled. Microscopy. Neisser's or Albert's stain. This stain will show the bacilli with metachromatic granules and in the typical arrangement. Albert's stain may show delicate green bacilli with purple-blue metachromatic granules. The granules are often situated at the poles of the bacilli, are called polar bodies. Loeffler's methylene blue. The granules take up a bluish-purple color and are, hence, called metachromatic granules. However, the bacilli may not always be demonstrable in smears from the lesion. Confident differentiation from some commensal Corynebacteria normally found in the throat may also be difficult. Gram or Leishman stain smear. This is done to rule out Vincent's spirochetes and fusiform bacilli, responsible for Vincent's angina, which clinically resembles diphtheria. Immunofluorescence. Diphtheria bacilli may be identified in smears by direct immunofluorescence test. This is more specific as the smear is stained with specific antibody. Isolation of culture is done by inoculating on Loeffler's serum slope, Tellerite blood agar, or Tinsdale medium. Blood agar is used for differentiating staphylococcal or streptococcal pharyngitis that stimulate diphtheria. The Tellerite medium is particularly important in the isolation of diphtheria bacilli from convalescents, contacts, and carriers, as in these cases they may be outnumbered by other bacteria. Biochemical reactions. Hiss's serum sugars ferment glucose, galactose, maltose, and dextrin with the production of acid but without gas. They do not ferment lactose, mannitol, or sucrose. It is necessary to use Hiss's serum sugars for fermentation tests. They are H2S positive and reduces nitrate to nitrite. Proteolytic activity is absent. They do not hydrolyze urea or form phosphatase. Demonstration of toxicity, virulence testing. Any isolate of the diphtheria bacillus should be tested for toxigenicity for the bacteriological diagnosis to be complete. In vivo tests include subcutaneous test in which 0.8 milliliters of the emulsion from an overnight culture on Loeffler's slope is injected subcutaneously into 2 guinea pigs, one of which has been protected with 500 units of the diphtheria antitoxin 18 to 24 hours before. If the strain is virulent, the unprotected animal will die within 4 days. The method is not usually employed as it results in death of the animals. Intracutaneous test in which 0.1 milliliters of broth emulsion of the culture is inoculated intracutaneously into 2 guinea pigs, which receives in different sites. 0.1 animal acts as the control and should have received 500 units of antitoxin the previous day. The other is given 50 units of antitoxin intraperitoneally 4 hours after the skin test in order to prevent death. Toxigenicity is indicated by inflammatory reaction at the site of injection, progressing to necrosis in 48 to 72 hours in the test animal and no change in the control animal. An advantage in the intracutaneous test is that the animals do not die. In vitro tests. Elix gel precipitation test. A rectangular strip of filter paper is saturated with the diphtheria antitoxin, 1,000 units per ml. The strip is placed on agar plate with 20% horse serum, while the medium is setting. Sheep or rabbit serum also be used instead of horse serum. The cultures to be tested are streaked at right angles to the filter paper strip. Positive and negative controls should be tested. The plate is incubated at 37 degrees Celsius for 24 to 48 hours. Toxins produced by the bacterial growth will diffuse in the agar and, where it meets the antitoxin at optimum concentration, will produce a line of precipitation. The presence of such arrowhead lines of precipitates indicates that the strain is toxigenic. No precipitate will form in the case of non-toxigenic strains. This test is very convenient and economical, but some brands of peptone and some samples of serum do not give satisfactory results. Tissue culture test. Bacteria incorporated into agar overlay of cell culture monolayers. The toxin produced diffuses into the cells below and causes lysis of the cells. PCR. Polymerase chain reaction for detection of toxin gene, TOX, has been developed to detect the presence of genes coding for the toxin in clinical isolates. ELISA. The test may be done to detect toxin from the patient's isolate using antitoxin and enzyme substrate system. Epidemiology. Diphtheria is a disease that is widely distributed, particularly in poor urban areas where crowding occurs and vaccine-induced immunity has a low protective level. Corynebacterium diphtheriae is preserved in the population as the asymptomatic carriage occurs in the oropharynx or on the skin of immune people. The infection is limited to humans and usually requires contact with a case of diphtheria or a carrier. Humans are the only recognized reservoir with oropharynx or skin surface carriage. Diphtheria is predominantly a pediatric disorder, but in areas where there are successful immunization services for infants, the highest prevalence has moved towards older age groups. Acquired diphtheria immunity is mainly due to the toxin-neutralizing antibody, antitoxin. Passive immunity in utero is gained transplacentally and can last for 1 or 2 years after birth. Skin infection with toxigenic Corynebacterium diphtheriae, cutaneous diphtheria, also occurs. Prophylaxis. Protective immunity. Diphtheria is a disease which is due to the toxin and not the invasion of the pathogen. Therefore, the protective immunity is dependent on the levels of antitoxin antibodies present in circulation. The objective of immunization is to increase protective levels of antitoxins in circulation. Vaccines. Diphtheria can be controlled by immunization. 3 types of immunizations are active immunization, passive immunization, and combined immunization. Active immunization. Diphtheria immunization is done using a killed vaccine. Currently, 2 preparations are available for active immunization. Formal toxoid, also known as fluid toxoid, is prepared by incubating the toxin with formalin. Adsorbed toxoid is purified toxoid adsorbed onto insoluble aluminium phosphate, less often the hydroxide. It is much more immunogenic than formal toxoid. Dosage. Diphtheria toxoid is usually given in children as a trivalent preparation containing tetanus toxoid and pertussis vaccine, as the DTP, DPT, or triple vaccine. For young children, diphtheria toxoid is given in a dose of 10 to 25 LF units. Schedule. The schedule of primary immunization of infants and children consists of 3 doses of DPT given at intervals of at least 4 weeks, preferably 6 weeks or more, followed by a 4th dose about a year afterwards. A further booster dose is given at school entry. Common side effects includes injection site reactions, redness, warmth, swelling, tenderness, itching, pain, hives, and rash, fever, drowsiness, fretfulness, vomiting, anorexia, persistent crying in infants, and rarely, convulsions. Passive immunization. Using antitoxin or ADS, antidiphtheritic serum. As an emergency measure when susceptibles are exposed to infection, subcutaneous administration of 500 to 1,000 units of antitoxin or ADS, antidiphtheritic serum. Risk of hypersensitivity is horse serum used. Combined immunization. This consists of administration of the first dose of adsorbed toxoid on one arm, while ADS is given on the other arm, to be continued for the full course of active immunization. Ideally, all cases that receive ADS prophylactically should receive combined immunization. Treatment. Antitoxic and antibiotic therapy. Antitoxin should be given immediately when diphtheria is suspected, as the fatality rate increases with delay in starting antitoxic treatment. The recommended dose is 20,000 to 100,000 units for serious cases, half the dose being given intravenously. Antitoxin treatment is generally not indicated in cutaneous diphtheria as the causative strains are usually non-toxigenic. Corynebacterium diphtheriae is sensitive to penicillin and can be cleared from the throat within a few days by penicillin treatment. Erythromycin is more active than penicillin in the treatment of carriers. The supportive care for diphtheriae may include hospitalization, monitoring of vital signs, oxygen therapy, completed bed rest, prevention, and vaccination. Diphtheria is easily prevented with the use of a safe and effective vaccine. Most people receive their first vaccination for the disease as children. This is known as the DTP vaccine, diphtheria tetanus pertussis. DPT, diphtheria tetanus pertussis, is a 3-in-1 vaccine. DT, diphtheria and tetanus, is a 2-in-1 vaccine, and TD, tetanus and diphtheria, is another 2-in-1 vaccine for adults.